Good afternoon. Sorry for being slightly late. I had a board meeting of ESTRO and we couldn't manage to finish at 5 o'clock. So I'm very happy, proud at the same time that our patients, because we should recognize that this trial was designed in '92, that's 21 years ago, that we can finally present the results of this trial. Now, it's on behalf of a lot of investigators and even many more patients, and we have no conflicts of interest to declare. What is this trial about? It is on patients with breast cancer. And patients with breast cancer, we are all aware that we treat the breast, and most often that we also treat or examine the axilla. But apart from the axilla, there are other lymph nodes. And the lymph nodes that we tested whether treatment with radiotherapy was of value is the internal memory lymph node, which is behind the breastbone, and the lymph node area, which is just above the collarbone. So in fact, the part of the lymph nodes which is not operated by the surgeon. From the past, and that's from the 80s, we know that in patients who have no axillary node involvement, that the risk that there is involvement microscopically is low, is in general below 10% for all patients together. Now for patients who have involvement of the axilla, the risk of involvement can be quite high, and this is variable. In between, a very wide range, 16 to 65%, but there are a lot of factors which can explain that. The size of the tumor, and also the position of the tumor. Because if the tumor is located centrally or at the inner side of the breast, the risk of involvement of the lymph nodes behind the breastbone is quite higher. This is a display showing the lymph nodes that we examined, and in the lower part you can also see a patient with a recurrent tumor and a CT scan and an enlarged lymph node, which is in practice rather rare to find. The study was designed to examine the value of irradiation to the internal memory nodes and the medial supraclavicular nodes in either patients who had involvement of the axilla or patients without involvement of the axilla, but in that case the tumor should be located centrally in the breast or at the medial side. The main endpoint was overall survival because, as I mentioned earlier, the demonstrated involvement of those lymph nodes was mostly microscopically and rarely detected on a clinical level. Secondary endpoints were disease-free survival, metastasis-free survival, and the cause of death. The trial, designed in '92, only could open due to a lot of reasons in '96, and in a time span of 7.5 years, we accrued a total of 4,004 patients. This was a trial which was run in 13 countries by 46 institutions, and currently we have a median follow-up of 10.9 years. The maximum follow-up was nearly 16 years. The survival status, which represents the primary endpoint of the trial, is as follows. Around 80% of the patients are still alive. There's a slight difference between the two groups. In the patients who were not irradiated to the lymph nodes behind the breastbone and around the collarbone had a 10-year survival of 78.6%, while the patients who were irradiated to those lymph nodes have a survival of 80.9%. This is a small difference of 2.3% in absolute number. We examined, of course, the cause of death, and what I highlighted with the rectangular bar is that only death due to breast cancer was decreased. There was no difference for death due to other causes, other cancers, cardiovascular disease, toxicity, other chronic disease, etc. So only breast cancer-related deaths was decreased by irradiating those lymph nodes from 21.4% to from 310 patients in the group of 2002 to 259 in the group of 2002. Looking to where the patients recurred, as expected, there was an influence on the regional recurrence rate in the lymph nodes. This was also, as expected, rather small in the patients not irradiated to the lymph nodes. It was 4.2%, in the patients irradiated to the lymph nodes, 2.7%. I would like to remind you that once a patient develops metastasis, the lymph nodes are not really examined anymore into detail. Local recurrence was exactly the same in both groups, 5.3%, 5.6%, no difference. Second breast cancer, also no difference even, but this is not a difference, slightly lower in the patients who were treated to the lymph nodes. But especially on distant metastasis, there was a clear difference, 19.6% without treating the lymph nodes to 15.9% for patients who have been treated on the irradiated on the lymph nodes. So concluding, primary endpoint, overall survival at 10 years, irradiation to the lymph nodes behind the breastbone and around the collarbone, increased survival, actuarial survival at 10 years from 80.7% to 82.3%, which is a reduction in the death rate with 13%, hazard ratio 0.87. This is, in statistical terms, just not significant, 0.0556. But when adjusted for stratification factors, this is a technical term and a technical issue, then it just becomes statistically significant. So it's just around the level of significance. Secondary endpoints, disease-free survival, metastasis-free survival, and cause of death. There, all three were statistically different. In favor of irradiating the lymph nodes, disease-free survival increased from 69.1% to 72.1%. Metastasis-free survival from 75 to 78. And for the cause of death, there was only one difference, and that is that patients treated to the lymph nodes had a lower risk of dying due to breast cancer. We have to thank a lot of people, especially the patients for sure, also the ERTC headquarters. We had a grant supporting this trial, supporting the ERTC, and we had also a grant supporting the quality assurance, which has been run very roughly in the framework of this trial. And these are the contributors, the investigators that are not among the authors of this abstract. Thank you very much.
So thank you very much, Philip. And as you are probably aware, we can now welcome our Congress Chairman, Cornelius van der Velde, who is sitting on my right. But what I would take this opportunity now to do is to take questions from those of you present. And if you like to, as I mentioned before, if you wouldn't mind giving us your names and your representations, and then we will address your question.
Hi. Caroline Helwick, ASCO Post. For Dr. Hody, so how do you explain the plateauing? What is the mechanism? I mean, what do you think is going on? Are these patients that survive that long different in any way? And also the press release indicated that some people, that there were no deaths after 7 years. So you didn't mention that. Would you elaborate on that?
Yeah, so the primary analysis was not about toxicities. This is a retrospective look at the data. So overall survival is kind of a cleaner endpoint. I mean, it's easier to follow that. And so the toxicities was not a focus of the analysis.
No, I didn't say toxicity. I said that anyway, go ahead. But I wasn't asking about toxicity.
You were asking about treatment-related deaths.
No, well, you said after 7 years there were no deaths, no patients died in this group if they were alive at 7 years.
Yeah, so there was a little bit of heterogeneity in terms of how much data was follow-up, so that most of the patients had follow-up between 5 and 10 years. And so if patients, you're asking how to explain that?
Yeah.
Well, we don't. They're all going to be theories at this point. So we could talk about the interaction of the host immune system with cancer, and at some point in the balance between the tumor growing and the immune system balancing, that immune system attacking it, that there is the ability for the host to have some homeostasis and being able to treat this like a chronic disease now, where the tumor cells are either present or not, and then those that are present are being kept in check, whether they by the immune system and not progressing. So I think that if you're able to induce that homeostasis in a patient, that you can try to turn a disease like melanoma into a chronic disease, which is what we try to do every day. And so from the data that we have in follow-up, and remember that the 10-year follow-up is a subset of patients that we have data for, and so it's hard to comment beyond that 7 to 10 years really accurately. But that plateau, I think, follows out from the early phase 3 data now with multiple studies going out many years now can't help but be intriguing to that in terms of the comfort we have now in giving ipilimumab to patients with melanoma and what the benefits are long term.
My question is for Dr. Poortmans. I'm Alice Goodman with the ASCO Post. I have two questions for you. The first is there was a discrepancy in the 10-year survival. On one slide it said 78.6% versus 80.9%, and then in your conclusion, I think it was 80.7% versus 82.3%. What is that? Which one should we report?
In fact, the first one is the absolute survival, and the second one is the actuarial survival.
Oh.
And the actuarial survival corrects for follow-up and missing data. So in fact, the actuarial survival is more correct.
Okay, and my next question is, we're reporting for a U.S. audience, and I don't know if it's standard of care to radiate those lymph nodes, the internal mammary chain and the supraclavicular lymph nodes in the U.S. Is it standard of care or not?
The debate exists for more than 20 years. In fact, in '88, US colleagues wrote "but a hockey stick" because it has the shape of a hockey stick on ice. And it's about 20 years that the internal mammary lymph node region in general is not treated in the US. There is a new initiative from Canadian colleagues who investigated the same and had the same results as our trial. A little bit more recent trial. They have only follow-up of 5.8 years up to now, but already with a clear benefit for treating. And he is setting up a new study with a different surgical approach to the axilla. And the US colleagues already stated that they intend to participate in the new study and consider treating more of the regional lymph nodes, but only in a subgroup with clear involvement of the axilla. While we have shown, and I had only 6 slides that I could prepare, we have shown that the effect of the radiotherapy is also evident in patients who have no nodal involvement, but the tumor located centrally or internally in the breast.
Walt? Cotrio from Belgian Oncology News. Question to Professor Hody. What is your current treatment algorithm for metastatic melanoma now?
So the algorithm hasn't really changed. So we have available, at least in the United States, BRAF inhibitor, MEK inhibitor for BRAF-mutated melanoma, and ipilimumab for patients with melanoma. So there's different styles, but in general, in kind of our practice, we have a discussion of all the above, and based on BRAF status, for patients who need immediate treatment due to being symptomatic from their disease or fast-growing disease, and they have BRAF mutation, that's usually one of the considerations for first is a BRAF inhibitor. Or for patients who do not have rapidly growing disease or are not symptomatic, we typically have a discussion of immune therapy versus target therapy. With the immune therapy, offering you that so-called tail the curve phenomenon I was trying to highlight, where a subset of patients have very long-term survival benefit. We know that the target therapies are highly effective, but their time to progression is limited. And so it's a true discussion with the patient based on where their disease is and kind of what we're trying to do together in terms of their goals. But there are trials in the United States that are trying to start to look at the sequence for at least BRAF mutated melanoma patients. Their tumors are mutated, which is about 50% of patients with melanoma. So there are trials that they're trying to answer the question of sequence. So do you give targeted followed by immune therapy? Do you give immune followed by targeted? And of course, there are trials that are trying to answer, is there a benefit to trying to combine these two modalities in some way formally? And those are all, I think, very big picture questions that are being investigated right now. So sorry for the long, it's a good question that's hard to give a short answer to. So in general, maybe our sense is the immune therapy we would discuss first in the non-symptomatic patient, regardless of their BRAF tumor status, because that may give you that long-term survival benefit. But all of those are great options for patients, and which one and how to really sequence things and combine are very active areas of current investigation. Thank you.
Thank you.
For Dr. Poortmans, Walter Alexander with Doctor's Guide. You showed the data for disease for distant metastases, and you said it was significant, but there was no p-value. I don't think you showed that on the last slide. Do you know that offhand?
There was a p-value for distant metastasis-free survival. For one, it was p04, and for the other, p02. But can we go back to that slide? But it's indeed, that was statistically significant.
Okay. Could we check that microphone? Is it actually working?
Here you can see it for disease-free survival, p044, and for metastasis-free survival, p02. Please.
Thanks, Philip. Yes.
Susan Mayer, freelance writing for the BMJ. Question for Dr. Poortmans. What is your practice going to be now based on your findings?
It's in fact the excellent question I was waiting for, because currently we are the only center in the Netherlands that routinely irradiate the internal memory lymph node region in high-risk patients. This group of 4,004 patients include stage 1 to 3, with about an equal distribution for stage 1, 2, and 3. And in fact, we saw that most of the benefit lies in, there is a trend, lies in patients with either low-risk disease, no nodal involvement, or patients who were treated with both hormonal and chemotherapy. So it looks like that the regional intensification of treatment has most effect in patients who have the lowest risk for metastasis, either because they had a lower disease burden, no nodal involvement, or because they were treated more effectively with systemic treatment, killing effectively the already microscopically spread disease outside of the breast and the lymph nodes. And this has to be further, of course, analyzed, but it looks like the better we treat already present metastasis, the better we can improve outcome with an optimizing of local regional treatment.
Good, thank you. Use the microphone,
Introduce
please.
yourself, please. Sorry, Barbara Nasto, Nature Publishing Group. Are you going to drill into this data at all, like looking for some sort of characterization of the people who kind of live 10 years versus the ones that don't make it 3 years? Because, I mean, I heard you sort of assume it was their immune system found some homeostasis. I mean, can you really rule out that there isn't something about the disease that they have as well?
Sure. I mean, it's how the immune system identifies their disease and keeps it in check. So you're asking the question that's kind of been a theme of question is there any way to predict that 20 to 22% of patients are going to have a long-term benefit as a kind of a predictive biomarker. And it remains an active area of investigation. It's probably not quite that simple. There are many factors that can be involved. It's not as linear thought process as having a mutation and hitting a gene and getting a result. It probably is combinations of the patient's tumor and maybe the genetic makeup to the immune system. What other aspects? It's likely a combination and may be more than one factor involved, so it's probably complicated. But there are active investigations looking at blood markers, tumor markers, in order to try to give a prediction as to which patients could have a long-term benefit, and those are ongoing, and nothing with a high sensitivity and specificity has been reported yet.
I guess I was wondering, are you going to do anything with your 4,000? Like, is there a way of kind of going back to that? Because that's quite an impressive set. You know, it is a retrospective set, but, you know, the hospitals keep paraffin slices of these things. And, you know, I was just wondering if there was any strategy on your part to go back.
Yeah, so there's always the desire to do that. There's some other opportunities with some other trials where there's a lot of more sample collection, a lot more details gathered about the primaries, for example, or the lymph node metastases and things like that. So in those data sets, that is possible, and we are working on trying to do that. With this data set, it is retrospective, it is multiple trials, and overall survival is as I mentioned, is a clean endpoint. You can collect that fairly easily, data. The other characteristics are there, and those sub-analyses will probably be done, but in terms of that, it's much harder to have a clean data set that way. But you're asking extremely important question, and likely in a trial where there's more in terms of consistent, rigorous collection of specimens that could be and how they're analyzed, that we could try to answer those questions, and some of those are being done.
Good, thank you. One question down here on the right, and then the microphone can come to this colleague here. Yes, please.
Hi, it's Kate Kellen from Reuters. Again, for Professor Hody, and maybe some of the other people on the panel could comment on this. Would you then also describe what's happening in your patients as a clinical cure, or is that going too far? And I wonder whether you could, in layman's terms, just describe, what this means in terms of melanoma treatment and how it's changed over the last. I mean, I remember even 3 or 4 years ago, people saying the patients just never lived longer than 6 months, and now they have time to get to know them before they die. And this whole scene has changed so dramatically. I wonder whether you could give me a sense of how that feels and what hope there is in the future.
Sure. So it's another interesting question. So a few years ago, we could never imagine using the C word, cure for melanoma. And to see some patients living long term, I mean, so how do you define a cure? I mean, some patients may have all their disease go away and may be in remission. Some patients may still have things in their CAT scans that just don't change. So our goal as clinical investigators is always to find something that cures patients of their disease. But at least what we're showing here is that we have a great paradigm shift of maybe curing a subset of patients. It's hard to use that term, but at least turning their disease into a chronic illness, which is a huge paradigm shift from where we were just a few years ago, where there really were very few things that did this to patients, more than just a few percentages. So we're headed that way, and I think it's important to say that in a very short period of time, with this as an example, and now with long-term follow-up, and with everything else being developed both in target therapies and other immune therapies that are coming behind it as version 2.0, 3.0, that we can start to, at least as a clinician to our patients, have discussions of turning this into a chronic illness, which we couldn't even imagine a few years ago, and possibly in a subset of patients begin considering using the C word, using cure. But I remain optimistically conservative on that point, though. So we're definitely headed in the right direction.
But nonetheless, this is a unique data set. It's a large data set, and patients with melanoma are living longer, and I think that's important to get that out there.
Good, thank you. Would you like to?
Anderson with Trends in Medicine. Dr. Hoodie, I'd like to follow up on the question about the 20 to 22%. Because the curves are so reproducible, why are you dismissing the idea that it's not another kind of mutation that we just haven't identified yet? That these aren't...
I'm not dismissing it.
You seem to be doing that, so thinking it was like some immune part of their system or something.
I'm not dismissing any of the above. The fact matters, I just admitting that I don't know. And my best educated guess at this point is it's probably a combination of things. And it may not, I mean, and this is purely my speculation, is that it may not be a single mutation, but it may be a combination of the tumor makeup and the patient's immune system makeup that is allowing this to happen in that group of patients. I'm simply just embarrassingly don't know what the answer is yet, and hopefully we'll know someday, so we can figure out how to best gear and personalize such a medicine for patients.
Fine, thank you. We'll take one more question from ourselves, and then I'll ask over the phone to see whether there are any questions coming in from outside. So please.
Just one more for Dr. Hoodie. Previous treatment. So that could have been anything when you say patients were previously treated or not. Would you tell us what the previous treatments were?
It's any prior treatment for metastatic melanoma. So most of these data were prior to the BRAF era, but certainly that could have been a possibility. But most of them would probably be chemotherapy, interleukin-2, whether they got adjuvant interferon or something like that. But it's hard. It's a mixed mash of things. Yes.
Yeah. Okay. Thank you. May I ask now on the phone whether there are colleagues who wish to ask questions?
Timmy and Bennett from Bloomberg News. Can you hear me?
Yes, we can hear you.
Yeah, question for Dr. Hoodie. Can you just maybe talk about the PD-1, anti-PD-1 antibodies that are in development now, and what difference you think that will make to the treatment of metastatic melanoma? Thank you.
Yeah, thanks. So the PD-1, PD-L1 antibodies are moving very swiftly through clinical development. So they're all investigational agents. There are no PD-1, PD-L1 antibodies currently approved. There have been presentations and some in manuscripts that have shown significant activity for this kind of next generation of immune checkpoint blockade that remains very promising in terms of responses and durability and tolerability. So I'm trying to remain open and honest and not have too much hype, but I have a tremendous hope that those antibodies will also prove beneficial to patients. And the field is moving extremely fast, where the phase 3 studies for PD-1 antibodies are already ongoing, and combinations of ipilimumab with the PD-1 antibodies also ongoing. Other combinations with PD-1, PD-L1 antibodies and other modalities are also being developed very swiftly. So you could have a whole day of press conferences talking about each of those different modalities, but the big picture is that is another kind of building upon the initial experiences with ipilimumab, another group of agents that have tremendous promise both in melanoma and other cancers now. And the registration trials are ongoing that will hopefully shed further light onto this and further details. But that being said, it is a different set of additional paradigm shift. So the ipilimumab is probably taking the brakes off the immune system in a way that's kind of maybe pushing the T cells into the tumor or reactivating T cells or immune cells in the tumor. And the PD-1, PD-L1 antibodies is working at the site of tumor. So many tumors produce PD-L1 that when it's expressed, it causes the T cells to die. Actually, they go to apoptosis, they die. So we're taking the brakes off in the tumor microenvironment with these antibodies. And so that's why this biology is quite complex. What is it about the tumor that causes it to express PD-L1? What causes it about the immune system with PD-1 and how it interacts with other cells in the tumor microenvironment? and how do we combine these in a safe and effective way? So this is, really an amazing time in our oncologic treatment history for us to be able to have these tools and now understanding to figure out how best to treat patients. So these are highly promising modalities for patients.
Good, thank you. Are there other questions from outside the room? All right. If not, before I ask my colleagues to give you some personal recommendations, if you like, or personal illustrations of what you may be interested in over the next 3 days, is there anybody here present who hasn't had a chance to ask a question who wishes to? And if not, then I'll turn to my Congress chair. And Kark, if you'd like to say what your suggestions are.
For the highlights of the next couple of years, thank you, John. And I'm sorry that I came late. We had some arrangement in the preparation of the arrival of the king. Obviously, at the presidential sessions, all these studies are with results that change our daily practice in melanoma here and breast cancer. I must say that the breast cancer study surprised me a lot because previous surgical studies didn't show any difference at all. So we thought it was a tumor biological question on local regional that had no effect, and it had to have an effect. So we have to consider in our national guidelines how we can implement and how we can change the strategy that, as you said, we had stopped irradiating internal memory chains for a long term, but we have to adapt regimens now for metastatic melanoma. So in many sessions there are from up to screening and the results of long-term results of randomized studies on screening up to genetic profiles like tomorrow on rectal cancer and the outcome of a randomized trial where in rectal cancer a randomization took place between yes and no chemotherapy, and the results will be presented whether it has an effect on survival. So in all the sessions, the presidential sessions, there is news that has direct implications to our daily practice, and we have to go back and discuss that with our national guideline committees, how we can incorporate those results.
Okay, thank you, Kark. So presidential sessions are a must. They're in the middle of the day, as I'm sure you know. Now I'd like to turn to my colleague and co-chair, Professor Cora Sternberg, and to ask her for her own recommendations.
Thank you very much. It's a pleasure to be here. My name is Cora Sternberg, and I'm the chair of the Department of Medical Oncology at the San Camillo and Forlanini Hospital in Rome, Italy. This meeting is a unique opportunity. It's a unique opportunity in Europe, and I think anywhere in the world, to have so many different specialists from so many different walks of life all together in one place. It's also the largest meeting of its kind. I think to see a meeting like this, where people from all different kinds of walks of life, young people, people working in translational research, surgeons, radiation therapists, can get together and speak and talk and debate problems. I don't think there's any other meeting ever of this kind, and this is a very, very important meeting for that reason. As a medical oncologist, there are many important new breakthroughs coming through, but I just want to tell you some of the areas that I personally think are very important. One is personalized medicine. There's been a lot of publicity about personalized medicine and giving the right treatment to the right patient. And this, I believe, is the way of the future. And we will see more and many different presentations about that. Clinical trial design. This also has to change. We can no longer give 1,000 patients all the same chemotherapy. We need new kinds of clinical trial design. This will be discussed. Not only will we discuss new ways of treating fewer patients with the right treatment, but we also will be evaluating things like how do we evaluate with these new oral treatments that are working so well and people are taking them for long periods of time, how do the small, what we call small toxicities, how do they affect people when they're given on a long term? And we have collaborations between academia and pharmaceutical companies and EORTC that what they're showing is that we have to look at these kind of toxicities or side effects, let's say, in a different way. The other thing is immunology. We've just heard that patients with melanoma are living longer. This is very important for patients. It's important to know. We have new immune checkpoint modulators, new immunologic therapies. We are boosting the immune system, and this is working in many tumors, not only in melanoma, but in non-small cell lung cancer and in prostate cancer. And in this meeting, you're going to be hearing a lot of that. And you're also going to be hearing a lot from the young medical oncologists who are going to be very involved in this meeting. Thank you.
Thank you, Cora. Well, I'm a radiation oncologist. Cora's given you some general features of the meeting, starting with personalized medicine. So maybe I can give you two examples just to give you those. One relating to radiotherapy. On Sunday at 8:57 in Hall 7.1, as part of the Profit Papers for Early Breast Cancer, Dr. Tram from Aarhus, on behalf of colleagues in Denmark and Oslo, are going to present a retrospective analysis of a large Danish trial testing the benefits of post-mastectomy radiotherapy and identifying on the basis of a genetic expression profile patterns of protein expression in tumors that have been stored since that time. They can identify not only those women that have got the most need for radiotherapy, that's what we call a prognostic biomarker, but also those which have got the most to gain from radiotherapy, what we would call a predictive biomarker. And those two elements together would help greatly to select those women that would both need radiotherapy and benefit from it. So that's one example. Then there's another example on the same day, a little later, 14:25 in room 7.1. It's one of Koch's presidential sessions, and it's coming from the expert, what we call the Expert C trial. Again, a retrospective analysis of a randomized phase 2 trial testing the benefits of a antibody blocking a growth factor receptor on the cell surface, called an antibody called cetuximab, that I'm sure many of you are familiar with, in patients with high-risk colorectal cancer, treated with chemotherapy, radiotherapy, surgery, randomized to plus or minus this biological agent. And they analyzed the function of a gene protein called P53, again, one that you've probably come across before and will be explained on Sunday. Whether that P53 protein is normal or abnormal has a major effect on whether the antibody treatment is effective. So there are two examples of personalized medicine, which would be one of the themes of our conference. Now, on Monday, obviously that after Sunday, I'd like to draw your attention in room D201 to the oncopolicy session. And this is looking into, for example, 3 policy directives from the EU. One, the EU research framework program called Horizon 2020. In other words, how does cancer research deliver greater benefits for patients over the next 10 years? Also, the new EU cross-border healthcare directives, which allow patients to opt to cross borders within the within the EU, to gain access to better treatments. And then the European reference frameworks for rare cancers, which clearly require continental scale research in order to benefit those individuals. And it's chaired by Alexander Egermont, a former president of ECHO, also currently the president of the European Academy of Cancer Sciences. And he will introduce an overview of EU action in the field of oncology by Tonio Borg, who is the EU Commissioner for Health. And so there's in fact a whole morning looking at EU policies for cancer research and treatment delivery, and including advocates as well. So I think that would be certainly something of interest to you. On the Tuesday, that's on our final morning, I'd like to draw your attention again in room 7.1, that's the big hall, at 9 o'clock. Another example of the interdisciplinarity, which will be another theme of our conference, bringing together scientists and clinicians who focus on breast cancer on the one hand and prostate cancer on the other. the thing that they have in common, although they have many differences clearly, would be that they are both responsive to the hormone profile within their respective men and women. And one obviously being responsive to testosterone, prostate cancer, the other to estrogen, breast cancer. And yet under the surface at a molecular level, many of the pathways that we refer to, the molecular pathways that actually interact between the hormones and the cancer cell are in common, or have certainly enough similarities between them to make cross-talking between the specialists valuable and informative. And so there's a 2-hour scientific symposium which brings together scientists and clinicians from both fields that will be talking to each other and with each other about what they can learn from each other. And then if these formal presentations that I've described are well, you want to change from them, then I'd suggest that, for example, at 5 o'clock on Monday evening, you could try one or other of the debates. And, for example, at 5 o'clock on Monday, you can listen to a debate where the motion is that this House believes that low-risk prostate cancer should not be treated as cancer. Or you can listen to a debate where the motion is this House believes that new radiotherapy technologies do not need to be evaluated in randomized clinical trials. And thirdly, that this House believes that the EU Clinical Trials Directive has harmed European cancer research. And that's what I had to say. And maybe before I close this press conference, I should give the opportunity to our two speakers, Philip and Stephen. Are there any things that you'd like to add at this point? If you don't wish to, then you don't need to, of course.
Thank you very much for all your words. It's very challenging, and it's indeed an excellent protocol. We should really focus on working together on the multidisciplinarity. And this trial, in a way, shows it, because the patients who are better treated or more intensively treated with systemic therapy, chemotherapy, and hormonal treatment benefit more from the radiotherapy. And just to highlight one thing, you see that the survival is increased by 1.6%, but that disease-free and metastasis-free survival is increased by 3%. How to explain that? That's very easy. Like in the presentation made by Dr. Hody, patients who have a recurrence do not immediately die. And that's for sure a very strong reason why we will redo the evaluation at 15 and at 20 years. If a patient develops metastasis after 7 or 8 years, at 10 years she will be still alive. We can treat the patients, we can try to make it a chronic disease, and we have to evaluate in the future whether it will be a truly chronic disease or ultimately the patient will die due to the metastasis. Personally, I think that the difference, the benefit of the radiotherapy will increase over time. We also have to check whether it will, at the long term, not be counterbalanced by an increase in late side effects. With modern technology, it appears in this trial and also in 2 other recent trials that there is much less toxicity compared to the trials done in the 80s and the 90s.
Okay, thank you, Philip. I'm sorry, Stefan, did you want a last word? Are you happy with, you've performed brilliantly, so you can relax.
I want to say that I think it's an amazingly exciting time for cancer therapeutic development. It's like the golden age between understanding the genetics, the target therapies, the immune therapies, and how the host responses and the tumor, and so everything is coming together in ways that we could never have imagined in just a few years ago from a number of angles, and we really, I think, are just excited in how this meeting represents that excitement of how these are being translated into patients for benefit. So I just have a great time. Enjoy.
Thank you. Just the last closing words from our president, please.
Yes, well, I'm a surgeon, and I will say something about surgery. I'm a surgeon from the Netherlands. And there is the largest increase in attendancy rate now of surgeons, almost 40% more surgeons from all over the world, from Asian countries, the US and Europe. And what is a surgeon getting out of this? Not only, of course, of technical aspects, how to adapt surgery and individualize surgery after neoadjuvant treatments, both radiation therapy as well as chemotherapy. But also we will discuss in our sessions whom should perform and where should we perform high-risk surgery in our ever elderly population. Because we have learned, and we have an exchange system now in Europe, that we compare the data that high-risk surgery carries direct operative mortality, and it is directly related not only to the experience of the surgeon and the surgical team, so there's a volume relationship, but also how well the multidisciplinary team acts. So there's also an infrastructural relationship, so that we are measuring this. And the future conference, because the ECHO conference are biannual, next year there's the radiation oncology, the medical oncology, the surgical conference will completely focus on those quality aspects of surgery, because surgery, the oldest treatment for cancer, is still perhaps also the most variable treatment for cancer, and we should adapt it to new molecular biological aspects of neoadjuvant treatment, but also to the individual patient, assessing the risk of this surgery and adapt it to the individual patient. So it has also attracted my community to this conference, especially because of the interaction with all the disciplines. So I hope you enjoy those interactions as well. Thank you very much.
Good. Well, thank you. And I think you and I meet at 8 o'clock tomorrow morning. Yes? Good. Thank you.